very plainly, when you're doing scar tissue, you have to apply pressure just a little bit deeper than the resistance of the underlying tissue in order to break it up. And you're very quick. You press, scrape, 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 and you get off of it. And then you stretch it for 20 seconds, and after that, that will break up the scar tissue. After that, it reacts like a normal trigger point if there's any left. Then you press until the tissue stops you, and you're only looking for especially sensitive areas. If it's a little bit sore or pain tender, it doesn't matter, just especially sensitive spots. Then you press until the underlying tissue stops you. You don't try and go past that barrier. And you say, tell me if it gets worse, gets better, stays the same, or flip-flops between them. If it doesn't change any more than that within 10 seconds, then you get off of it for another 20 or 30. If it starts to go away and keeps going away, you just hold it until it goes away or it reaches a real low ebb. That's how you do it. Basically, the most that you have to hold any point is 3 times. So you can get rid of things very quickly, mostly in one visit, very seldom more than that. But you have to follow that protocol. You can't be light on scar tissue. You have to go past that barrier and scrape, scrape, and get off of it. And this will help you to get patients well so much quicker, you're not going to believe it. Now, the way you manipulate the internal organs is you locate the navel. You make a plus and a times through it. Basically, for example, you come up under the rib cartilage here, spread your fingers as wide as possible, take about a 15-degree downward slant, take it to tension, give an impulse thrust, just the same as adjusting on a vertebra, for example. And you move about 2 inches, again, again, again. So you're going to take about 4 thrusts all the way across. You do the same up here, here. So you're going to do each of the 8 legs just the same. So you're going to go up and back on each one of those legs to free those organs up. And you can get some very amazing results. For example, I had a woman call. She said, I'm driving in from about 5.5 hours from Oklahoma, and my husband's been having a heart problem. We took him to the Oklahoma Heart Hospital 4 times. They couldn't find a problem, so we're bringing him to the Dallas Heart Hospital. We heard you did things different. And I said, well, tell me some of the symptoms. And they told me, and I said, well, kind of sounds like congestive heart failure, so drop by emergency room and see if that's it or not. They did, and they called me back. They said, no, that's not it. They ruled that out. I said, okay, bring him in. Basically, the assumption here is that the stomach was adhered to the diaphragm. The heart sits just above that. So all I did on this gentleman, just like this, like that, and he took a deep breath and said, finally, somebody got it, and the heart issues resolved just like this. So basically, the stomach being adhered to the diaphragm caused problems with the diaphragm moving. That in turn caused abnormal pressures on the heart. So once we unadhered it and the diaphragm started moving properly, the heart started functioning properly. Okay, let's talk about sleep apnea. Now, sleep apnea basically is a crowding of the back of the throat and not allowing the person to breathe at night, especially reclined on the back. But the problem is it also leaves the person without energy during the day because crowding of the back of the throat does not allow a lot of air to get in and out. So one of the first things you want to do is realize that the tongue itself is crowding the back of the throat. So basically, with a gloved hand, you would have the patient open the mouth, and you get a lot of saliva on there, say with 2 fingers, and you would go back and down, and the tongue attaches to the hyoid bone. So you would go behind and real quickly scrape, scrape, scrape and get out, because they're going to want to gag with it. Then you have them stick the tongue out and move it around really wide for about 30 seconds or so. And this is going to loosen up the circulation, the lymphatic drainage, and help stretch it out after that. Now after that, you go back in. This time you're going to go back down and again touch the hyoid at the tip of the fingers, and you will pull back. You're going to instruct the patient to breathe really deeply and slowly while you're doing this. You can do this standing as well as laying. And so you're going to go down and you're going to pull back, and you're going to have the patient raise the arm like this, and if they feel pain, as long as they're feeling pain, hold it up, and as the pain goes away, it drops. When it hits there, you merely come out. You're going to find that this unoccludes the whole back of the throat a great deal. Now if they're sitting up or standing, you would have them hold the hand like this and go down to here, for example. Now immediately after doing this, they're going to feel a whole lot of energy because you just opened up the back of their throat, and now a whole lot more air is going to get into the lungs, so it's very, very quick. Now second thing is the tonsils at the side, and I normally do this in maybe 2 or 3 different visits. The tonsils are kind of like radiator flaps, and they would sit here like this, but they're adhered together. So they might have been engorged or inflamed at one time. You have to go back in with your index finger and peel it away from the back of the throat, and then pull your fingers through the radiator flaps, and then peel it away from the front of the throat. And this can be very painful. If there's fresh pus in it or hardened pus, you're going to get that out. You may get some blood out as you're doing this, but it's going to allow the tonsils now to start draining. Then you would go over and you would do the other side. So that's the second visit, for example. Now the third one, you would go back into the Eustachian tubes. Now the Eustachian tubes, you would have the person open the mouth real wide, and you would take a glove finger and you would get a lot of saliva on the finger. Now the Eustachian tubes sit just up and out of sight on either side of where the uvula is hanging down. You can do this again sitting or laying. It doesn't matter. It may be easier sitting. But basically you take the middle finger and you lather it up with saliva, and you go beside the tongue with the middle finger, and you go back until you hit the back of the throat. Then you come up behind the soft palate, and your finger will drop in the Eustachian tube. Eustachian tube, you ought to be able to put your finger into the distal interphalangeal joint. And then you zip it up like this, and that basically opens it up and separates the scar tissue. Then you immediately pull out, go into the other side, do the same. Then you go to the back side. You're going to go entirely up behind that soft palate and kind of pull back toward you. You're going to scrape around, and you're going to get the adenoids at the same time. This is going to help the tensor veli palatini, which is what the uvula attaches to, and basically is a soft palate, to drain. The circulation goes to it. The weight that normally causes the snoring, that will thin out and go away, so you're going to have a lot less trouble with snoring. And doing all these 3 procedures is going to really help or eliminate sleep apnea. In addition, in a severe case of Eustachian tube blockage, it may be because there's this adherence to Eustachian tube. So opening this will take care of that and open up to the middle ear and allow it to drain out. Now, one of the things about the Eustachian tubes, when they're blocked, this is talked about by Travell and Simons as Eustachian tube stuffiness. I call it Eustachian tube deafness because it can be rather severe. Now, another way to get at it is to stick your finger up at the angle of the jaw behind it, and you'll feel at the tip of the finger the internal or medial pterygoid. Now, if there's a blockage there, you can do both these at the same time, just like this. And if it's due to a trigger point in that internal or medial pterygoid, you lightly but firmly press, and you just tell the patient, tell me when you hear a whoosh, and the eustachian tube opens. Normally that may be 10 to 20 seconds is about it. Now, another way to do it is to have the patient block off the nostrils on themselves, and they would take and put a very light pressure on the blocked side on the tragus, and they would take a breath in, purse the lips, and very slowly increase the pressure, and that will open the eustachian tube. This is perhaps the easiest way to do it without doing anything else, and it's very quick and easy. Anybody can do this in just a few seconds. Another way is to get an adult ear syringe, and I like the ones that you get at Walgreens. They seem to be the best to me. And basically you have the patient block one nostril, and you stick it in the other nostril, and you have the patient suddenly inhale. And as they suddenly inhale, you go like this, and it shoots a jet of air directly back in that inferior turbinate, and right behind it is the eustachian tube. And as they inhale, like in yawning, for example, that tends to open the eustachian tubes. Well, doing this also does the same type of thing, and that can be effective at opening that eustachian tube also. So here you can get rid of eustachian tube deafness. You can keep a child from having to have a tube put in their ears. So how do you tell whether it's eustachian tube deafness? Well, you ask a question. Do you have trouble driving or flying into altitude with getting headaches and getting a lot of pressure in your ears that just won't clear out even if you yawn? That is one. Another one, when you dive into a pool and you go below about 4 to 6 feet, does that cause a pressure so bad that you have to come up? If they answer yes to either or both of those, that's eustachian tube deafness. And you know that when you open the eustachian tubes, then that deafness will go away very immediately, which I've done on hundreds of cases. So here we have ways of keeping children from having tubes in their ears, fighting getting rid of eustachian tube deafness, and taking care of very convincingly sleep apnea. Now, somebody who has constant tightness in the sore throat, stiffness in the neck, it may be because of the muscles between the cartilage being infiltrated with scar tissue, or on the surface of the cartilage, on the front, on the sides, or on the back. So you would take your fingers above the hyoid and scrape real firmly between the hyoid and the thyroid cartilage, between the thyroid and the cricoid cartilage, between the cricoid and the tracheal. There's 3 tracheal cartilages here. You would scrape very firmly between them. Then you'd take the tip of your finger, go on the tips and between them, then shove it beside and go on the posterior aspect like this. And you would stretch each way for 20 seconds, just like so.
Yep.
So you'd have them look one way for 20 seconds, the other way. If you had a drop-away headpiece, you just use that also to extend the head and neck, put more of a stretch on it. Then you go back, and also you're going on the surface of the hyoid and the thyroid cartilages too, because it could extend off of that. And it frees it up, and this gets rid of a lot of constant tension directly on the throat area. Right, now we're going to talk about endonasal technique. Now Van Rump, who I learned from, had 4 different diameter sticks, hardwood shellacked that you put lubrication on. He would stick it in to here till it hit a bone and then go directly back in the lower turbinate, and you would lightly twirl it as it goes back, and you would hear and feel scar tissue snapping in there. And one of the benefits of freeing this area up is to free up so the cranials free up. Most people think of doing endonasal insofar as opening the sinuses up. So he would do progressively one stick after another. Now what I have is you can go to a specialty pharmacy and get a 6-inch Q-tip with the plastic stick. You don't want a wooden stick because you don't want it to break off. You put lubrication on that like baby oil or olive oil or something. You do the same thing. You stick it back in here, you go back, and it will go in all but maybe an inch or an inch and a half until it bottoms out at the back of it. Then you would take either a condom or a finger cot, which is how I learned finger cot, and you lubricate it on the inside and the outside. Take that same Q-tip, put it on the inside, stick it in to the lower turbinate, pull it out, and then you take a blood pressure bulb, put it on there, and either put a grommet on the end or have someone tie and hold a piece of twine to choke it off. Then you pinch, then you slowly press maybe 3 half strokes on that bulb, and it will dilate in there and it will open it up. And a lot of times either just sticking the Q-tip in there or doing this will do the job. The only problem is that expands back, either that or the condom will expand back and it won't thoroughly clear it out. And you might lose the condom, or if you don't keep a pinch on it, you might lose that finger caught back in there. So you have to keep a hold on it and untwist the blood pressure, the bulb, and deflate it and pull it out. Now those that use condoms always have a needle present because it's going to open up in the back of the throat. Most of the time they have to pop it and then pull it out the nose or out the throat. Now that only goes in the inferior turbinate. Now Van Rump also taught to use a finger cot or a surgical glove and lubricate it. For example, I'm on his left side, I use my left small finger and I would go down in with a very light pressure and it would gradually open up, and I might get as far as all the way up here. Now your finger has to be small enough to go in any given nose. I've had some just go up to the proximal interphalangeal joint instead of the metacarpophalangeal. When you get in there, then you flick the finger and that opens it up into the sinus opening. Here, now that's as far as Van Rump taught. But I discovered, I thought, you can shift up and go in the middle turbinate and up again into the upper turbinate, and then come out like this, sweeping across the nose, and get far more scar tissue. Then you go on this side. Now, when they sit up, there quite often is a lot of bleeding. So you have paper towels handy, and this is very painful and it's very traumatic. So I like not doing that as much as possible, but sometimes you got to do it. And as you found out in part 1, this can have an effect, the upper turbinates, on the vital organs, the heart, lungs, and kidneys, the middle turbinate on the digestive organs, the lower turbinate on the reproductive and urinary tract. We also show in part 1, if you didn't get that, you might want to, how to get it mostly from the outside. And now I do probably 98% from the outside instead of the inside. When you got a lot of scar tissue though, you got to go on the inside. And just doing the first couple of steps may be enough for that patient, and that may be all that they want, and that's fine. but some patients you got to go in with that finger and get the rest of it to really open it up. And I've saved several people from having to get a deviated septum surgically corrected by this. Now, if you get a lot of bleeding when they sit up and you have to cup it under here because it will come out, you have the patient pinch the thumb webs like this and press very hard. That will shut off the bleeding in the nose basically in about 7 seconds when you do that. So it causes a sympathetic reflex and shuts off the bleeding in the nose very, very quickly if you have that bleeding. Right, this is an EK Embossing Stylus Set. And basically what you have is 3 different prods with a different sized ball tip at each end. One is almost totally pointy, and you see there's different sizes. We're going to be using this as we go through this particular part. Now in acupuncture there are 3 main rules. The first rule is 50% of the time you work on the opposite side or the opposite end of the body to where the pain or symptom is. The second one is always treat scar tissue where you find it. And that basically means visible scars. We're going to talk about scars that you can visibly see, but others that are cutaneous or subcutaneous that aren't easily visualized. The third one is an acupuncture point or meridian, mostly affects AFF-ECTS, what it's named for and where it courses to. So I would advise anybody watching this to get a set of acupuncture charts so that you can see where they go. Now most of the endpoints on the acupuncture charts are around the eyes, around the fingertips, and around the toe tips, with a few exceptions to that. Now when we go to the visible scars, we would have, for example, a surgical scar like in this subject. And what you want to do is you want to go right down the middle of the scar. You notice I'm not going directly in. We're using a very small ball tip stylus, and it would be about the equivalent of a pen if you didn't have a stylus with you. So the ball tip of a pen. Here you want to go quickly right through the middle and right on the borders and right where you see some of these other outlying scars from the sutures. So you would hold it just about like you hold a pen. You're going to go just a little bit deeper than the underlying tissue resistance because you want to basically put perforations in the scar tissue. So you're going to go as such, just like this. Just that quickly. Then you want to stretch out the scar tissue basically for about 20 seconds to separate it. Then you would go back, and now you're just going to go until the underlying tissue stops you. You're going to look for especially sensitive spots. Now if it's a little bit tender or sore, I don't even worry about that. That'll rectify by itself. If it's especially sensitive, you would hold the spot, for example, like this, just until the underlying tissue stops you. You would hold it for a maximum of 10 seconds. You'd ask the patient, tell me if it stays the same, gets worse, or alternates worse, better, worse, better, worse, better. If it doesn't start to get better and continue to get better in that 10 seconds, release it and go somewhere else for another 20 or 30 seconds. Usually the third time you'll go back and it will either already be gone or it'll start to go completely away. And that's how you treat these. Now, do I always go to visible scars? No, I don't. It's only when I'm having trouble rectifying a particular symptom, then I will start to ask other questions about visible scars. And in your notes there is a questionnaire asking very specifically, you have scars here, there, here, or there. And because the patient may not remember a lot of scars. For example, I had a 13-year-old who's coming in for a low back problem, asked me, well, can you take care of flat feet? And I said, well, usually, who has it? Well, I do. And it was in the middle of the summer, and she was sitting on the table barefoot. And I said, well, your arches look fine. Well, yeah, but when I stand up, it just falls to the floor. So I said, okay, stand up. Sure enough, her left arch just fell flat to the floor. So I looked from the toes all the way up to the middle back and couldn't find anything. So remembering the opposite end, opposite side of the body, rule 1 of acupuncture. I asked her, do you have any scars on the top of your head? And she said, yeah, 3. I said, well, how in the world would you know that? When I was younger, I bounded into our van and cut the top of my head, and I had to have sutures put in 3 different scars there. So I went to the top of her head. Sure enough, there were 3 scars. I did this maneuver on her. Got rid of all the pain except one that wouldn't go away right away. So in that particular instance, I stuck an acupuncture needle in it, twisted it for 10 seconds, and left it there for a half hour. And I could have just as easily held it with the tip of the prod, but I didn't have time to, so I got a little bit lazy. So she comes in 2 days for the next visit, all excited. She said, look, look. She took her shoe off and jumped up and down, and the arch did not fall. I had another doctor ask, well, what about an episiotomy scar? I said, yeah, well, it's a scar. So he had a patient that had severe pelvic pain from, I think, about 5 to 7 years earlier after having the first child. And I think they had like 3 children, if I remember correctly. So he went and he used a small tip probe on the episiotomy scar. It was painful. As soon as he was done, all the pelvic pain that had been there for several years was gone. I had a patient that had severe hand pain, and I couldn't find any scar tissue, or nothing worked, and I asked, have you ever had a paper cut? And the patient said, well, yeah, I had one through a web. I thought it was going to cut right through the muscle. And you couldn't see it, it healed up so well. So I took the small tip prod, and I went right where she said it was. She couldn't believe it. She didn't, she didn't know that the pain was still there. I got rid of that pain. All the hand pain went away. Now, what are some scars that maybe we wouldn't consider scars? Well, wrinkles. And you can have a lot of, like, wrinkles in the hands, for example, or in the feet, in the fingers. Any of those would count. You'd have, like here in the throat, you can have it in the forehead. Had a woman come in a seminar, and there were the wrinkles in the forehead. Mr. Producer, if you could swing it over to the face, please. And she had severe migraines ongoing, and her face was all scrunched up. So I went up here and just went through the wrinkles on the forehead, and which were very painful, and her husband didn't even know it. And so I went through and relieved all those, and her face dropped, and migraine headaches went away. You can have acne scars. You can have tattoo scars. Doctor asked me, would tattoos count? I said, well, yeah, I'd never considered it before. After this patient had a tattoo, started having all these bizarre symptoms. So the doctor went on the tattoo itself and relieved it, and all the bizarre symptoms went away. And as a side effect, the scar or the tattoo itself diminished. And now she's getting all sorts of people coming in just to use the prod on it instead of like a laser for $100 per square inch or whatever it is. You can also have scars from old shingles. I had a couple of women who were in their 60s, and their mother had shingles in the side for 28.5 years, and the pain was still there. And said, can you help that? I said, well, bring her in. And so I took the small tip prod and I went over that, and it was about maybe 5 to 6 inches in diameter. It was severely painful. And I stretched the skin, got the rest of it, and in a matter of a couple of minutes, all that pain from the shingles, old shingles, was gone in a matter of just a couple of minutes. Now, there are basically 3 types of shingles. One that lasts for 3 weeks, one that lasts, and that's about 95%. One lasts for 3 months, that's 95% of the remaining 5%. And then those that last for years and years, maybe decades. So if a patient calls up and says, well, I have shingles, can you help? I ask, how long have you had it? And they say 2 weeks. I say, wait a week, it'll probably be gone by itself doing nothing, and it usually is. They call up and say, I have shingles, can you help? And I say, how long? And they say 2 months. I say, wait a month, it'll probably go away. And most of those do. Now, a doctor at a seminar had a patient that had shingles up under the armpit, and they still had to wash under there, and they used deodorant, band roll-on. They rolled band roll-on on it, and wherever the band roll-on hit, it caused the shingles pustules to shrivel up and go away. So he started telling people with fresh shingles to use regular band roll-on on it, and I have since, and it helps the shingles to go away very quickly without doing anything else. So let your mind kind of run wild, and if your patient is having bizarre symptoms, start thinking about visible scars, shingle scars, tattoo scars, wrinkles, etc., etc. And you may find a very quick and easy answer. Otherwise, I don't find it necessary to go for scars because it normally goes away with regular treatments. But if you get stuck and it's not going away, consider treating the scars themselves. Another area, if you're having trouble getting rid of symptoms, would be periosteum. Now, first we look for old fracture sites, and in your notes there's a questionnaire for old fractures because somebody may have some that they can't even remember. It helps them to remember, just like the visible scars. Well, the old fracture site, the fracture leaves a callus, and the callus is scar tissue, and you may have symptoms going off from that. And basically you find the old fracture site and you scrape over it with the big ball tip prod. And you stretch it, and then you use the 10-second rule that we elaborated on in the visible scars. That takes care of that. Also, you can use it on just regular periosteum of bone. Let's say the bone itself hurts. Well, you scrape over the periosteum of the bone. And that can get rid of a lot of pain just doing that, because there may be, you may have hit the hand, hit the fingers, and then some scar tissue set up in the periosteum. And I got this idea basically from Felix Mann, which is in your notes. He used periosteal pecking with acupuncture needles. I thought, how can I do that without using needles? And I came up with this, and it worked very well. Now, I had a seminar, a doctor brought a patient in that was having numbness and tingling and pain in wrist and hand on the left side in the 2 smaller fingers, the ring finger and small finger. Well, I didn't find anything to work on there, so I said, do you have any fractures? Did you fracture the opposite wrist? And he said, yes, as a matter of fact. So I go to the other side, and the fracture was on a bone in the wrist right here, so I scraped over it. He didn't even realize it was painful. We got rid of the pain there, and I said, how's your other side now? And all the pain and numbness and tingling had gone away in the opposite side. I gave this at a seminar and got a call back from a doctor. He said, you know, I immediately thought about a patient who had pain, numbness, and tingling, starting with the shoulder and going down the whole arm and into the hands. And I recalled that and I hadn't been able to affect it at all, he said. And I remembered that he had broken his clavicle 3 or 4 times. So I went and I scraped on the clavicle over the old fracture site. And it was extremely painful. And when I was done, all the pain and numbness and tingling in the shoulder, arm, and hand had gone away. And you may have it, and somebody may have hit their skull on the head. Well, you scrape over that. May have like fractured their cheekbone. You scrape over that. Broken their nose. Scrape over that. Broken the eye socket. You scrape over that. So just let your mind kind of run wild on the periosteum and the old fracture sites, because they may be something very big in getting rid of symptoms in that given patient. Now you may have scars in and around larger tendons. Here you have the anatomical snuff box. A lot of times these tendons are involved. What you do is you pop the tendons out and you scrape over them with your fingers, pinching very hard, just like this. Then you take one of the medium ball tip probes and you scrape underneath the tendon where you can't get to it, and right where the tendon attaches to the bone. And that can get rid of long-standing tendinosis, tendinitis in different areas. You can do this on the Achilles tendon, for example. You can do this on all of these. You can pop the tendons out in the wrist and do it on here. And this is very utilitarian. Pinch and scrape with your fingers, then use the medium ball tip probes to get under the tendon and go right on the attachment, and it can do wonders in that particular instance. Now you may have trigger finger. Trigger fingers occur because you have callus, which is scar tissue that's building up from an inflammation on a tendon that goes to a flexor in the finger, for example. And that tendon normally glides through a tendon sheath very clearly. But if the scar tissue gets a little bit too big to get through, then it pops through and you have the trigger finger. Normally you would have it somewhere in this area, and you would use a medium ball tip prod and you would scrape over that little bit of scar tissue, that callus on the tendon, and you would stretch it and you'd get the remainder, and very quickly you do not have a trigger finger anymore. Also, you can have Dupuytren's contracture. Now, Dupuytren's contracture, according to Travell and Simons, comes out of the palmaris longus muscle, and that attaches in the middle part of the hand. Now, in this case, the muscle comes from the forearm. The belly of the muscle is right here in the meaty part of the forearm. So you take the big ball tip probe and you would go right over the palmaris longus muscle, and then you would take the medium ball tip probe, and basically you can see the skin matting down over the Dupuytren's contracture tendons right in this area. So you would take and you would scrape over those tendons to liberate the tendons from the overlying skin. Now, if it's been there for a long, long time, the skin is matted down very hard over those tendons. Now, as you're doing this, you want to pull the fingers back to help free it up as you're doing this, okay? If it's been there a real long time, then you have to send the patient home and stretch it several times a day to help free the tendons up from the skin. And you may have to treat it many times on that. I've had many patients, we just relieve it on the very first time. Sometimes the skin is matted down so hard they have to go home and do that, and you have to treat them multiple times for it, however. Now sometimes the skin itself mats down over an area and it's not gliding over the area. So this can cause a reaction in the nervous system. For example, if the skin is not gliding over the area, it'll tell the brain stop, and it stops and may send a pain signal. So this can be painful or not. But basically, let's say you have low back pain or low back tightness or stiffness. Well, in order to get this skin to unadhere off of the back, you would ball it up like this. You're dragging your thumbs and walking the fingers to basically rip the skin from the underlying surface so that it has its mobility again. You can do this virtually anywhere in the body. You can do it over the shoulders, over the neck, you can do it over the forearm, you can do it on the back of the hand. For example, the back of the hand, just like this, the top of the foot, the forearm. You can do it on yourself on the forearm, just like this. Drag the thumb, walk the fingers. I've had several people get over carpal tunnel syndrome because of the skin matted down to the forearm right here and causing that. So you can use this anywhere in the body. I've had people come away from this seminar, they do nothing but the skin roll because it's so effective from the whole seminar and all this stuff that we learned from it. So please consider this at least in difficult cases, because this may make a huge difference in those cases that you've gotten little or no results on. In this case, you would have Bursa. Now Bursa, the skin may be more closely adhered to the bursa, so you have bursitis. So in that case, you would take your thumbs and, like on the infrapatellar bursa, and you would press and scrape just like this. You may have the underside of the kneecap, so you'd have to shove the kneecap to the side and scrape the underside of the kneecap on either side just like this. And then go back and get the residuals just like we talked about before. So this is an approach that would be good for Bursa, for example. Right, you may have scar tissue in the superior mediastinum, which is the largest gap between organs in the human body. The way that you reach it is behind the clavicle, approximately mid-clavicle to mid-clavicle, also going behind the sternal notch. Now you should be able to go up to the distal interphalangeal joint. You have the patient drop their chin to take the tension out, and you go behind the clavicle and the sternal notch like so, pressing firmly. If they have a lot in there, they're going to that's going to be painful. But you stretch about 20 seconds to each side. Then you go back in and use the 10-second rule just like we did before. And the scar tissue in this area can wrap around the trachea, can wrap around the bronchial tubes, can wrap around the esophagus, around the larynx and the pharynx. So it could cause a problem with the voice. Right between the sternoclavicular joint is where the lymphatics from the lower body and the upper right body and the head and neck drain in there. So it can have a big effect on retention of fluid in the upper and lower extremities, and from the sinuses and things like that. It can help changes in voice, can help gagging and choking and swallowing issues, it can help bronchitis and asthma. It can also help esophageal spasm in this area, which can mimic heart attacks. So this can be very, very beneficial from any of those standpoints. Now in transverse friction massage, it states right in Celiac's manual, you need about 10 to 20 visits and a very strong therapist to free up a single muscle, a single structure. On Graston, 6 to 10 visits, and you need his very expensive tools. In ART, 4 to 6 visits, and all these can be very traumatic. Well, normally we can release a muscle or a tendon or a ligament in just one visit with very few exceptions. Now the IT band can cover, of course it covers down to the knee, the side of the thigh, and attach up in this area here. And you think of hip socket, knee, and lateral thigh issues. We're going to show you several techniques to release that, and many things that it can help. Now the IT band actually wraps around and covers the vastus lateralis of the quadriceps, so when it's not gliding over the quadriceps, it can mimic that problem. That can explain why you're releasing the quadriceps really isn't working too good. It can wrap over the biceps femoris and cause hamstring issues. So if you're having ongoing hamstring issues, it may be because of the tibialis anticus, or excuse me, the IT band. Now, one way that we can go through this is imagine a line going straight through the middle of the lateral thigh, forward maybe an inch, back maybe an inch. And you take the leg in a figure 4 aspect like this, and you're going to take your elbow, press a little bit deeper than the underlying resistance, and you're looking to just perforate the scar tissue. Now the proper stretch is in Ober's sign is to extend the leg, take the ankle headward and press downward. And when you do this, there's no way the heel is going to hit the back of the buttocks. You just merely pull it into the buttocks and lift, and that's getting the rectus femoris, and just pulling it into the buttocks without extension, the regular quadriceps. So you hold this for about 20 seconds, and here I'm just hooking my hand under it. My arm is very straight, just taking the back of my other hand and doing the stretch at the ankle. And so I'm putting very little effort into this. And you put it back down, you go over the same spots, and you apply the 10-second rule to it. Okay, here are some tools that you can get from a hardware store like a Lowe's or a Home Depot. And this is an S-hook, and you notice the ends are pinched in. Most of them you get, these and these are parallel. This is thinner than the spring link. And the spring link is such a size that you can easily lay it in your hand and use it a whole lot easier than a T-bar, for example, that Nemo used, receptor tonus. Here's another spring link, and basically it has a very small ridge. This you can keep in your pocket, and notice you put your thumb against here and you can press and scrape with this to get a desired effect. And we're going to show you how to use these. This one you press down like this and scrape and get the desired effect. Here you're just laying the palm of your hand, you're not gripping like this, you're just laying it in the palm of your hand and just pressing down and getting the desired effect. And we're going to describe how to use it in several different forms or fashion. These are very inexpensive, just like the prods, the Embossing Stylus Set that we had before. So your total investment in tools per se isn't hundreds and thousands of dollars. We have an investment maybe at best of $50 when you have all of these, and probably a lot less than that. Now in Turk's Orthopedics, it has a very interesting photo on page 530 of volume 1, which is in your notes. And it shows that a tense iliotibial band can pull down on the iliac crest, and that puts tension on the transversus abdominis out here and the quadratus lumborum, which pulls down on the ribs, and it shows it can cause a scoliosis. Now, one of the things that I found is that if you go down again here on the side that the patient is having the symptoms, in the middle back especially, you scrape right at the insertion on the superior lateral aspect of the fibula, just like this, with the spring link or carabiner. They're going to have a lot of pain only on that side, but not the other side. And again, you press until the underlying tissue stops you, and just a little harder, so it's going to be press, scrape, 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 scrape. Then you do the stretch as we showed earlier. Then you go back and you get the residual with the 10-second rule, and immediately they're going to notice that the pain and tension went out of the thoracic area because you took away the pressure on the iliac crest, which in turn took away the pressure up here in the ribs. And it's going to relieve that curvature up here. Now, some patients will have a very hard time crossing their legs. Either they can't do it at all, or they have to reach down and lift the ankle up to do it. This is a problem mainly with the sartorius muscle right here. Now, the sartorius and 3 other muscles, namely the gracilis, semimembranosus, and semitendinosus, attach just below the tibial condyle on the medial side right here. And this is where the issue is, right at the tendinous insertion of the pes anserinus. So you take your thumb and you press very deeply and scrape just like that. And since this is the action, the stretch would be in the opposite direction. And you hold that stretch for 20 seconds, and you go back and you apply the 10-second rule right here. Now, obviously the patient may not be able to even lift their leg to do this, but what you'll find is right afterwards they will be able to lift their leg higher and cross it like this. Now, if they haven't been able to do it for a long time, they may forget that they also have to lift the leg high to cross like this, so you have to remind them. This immediately, after you release the pes anserinus, will enable them to cross the legs either without help or much easier. But you may have to tell them to lift their leg higher. Now, sometimes you have a knee pain that is from a little nodule. You go to the superior lateral aspect of the kneecap and up maybe 3/4 of an inch or so, and there's a nodule there. And you can feel right over it, and you're pressing very deeply. And you scrape that, and they come undone. And then you bend the knee basically for 20 seconds. Then you go back on it, on that nodule, and you have a light but firm pressure on it, and you apply the 10-second rule as we discussed before, and you'll find that a lot of knee problems were coming right out of that nodule right there. Now here you have a nodule like the one in the thigh, only it's in the elbow, but it's on the ulnar nerve. So you're going to find the olecranon process of the elbow. You're going to go just medial. You're going to go up maybe a 1/2 inch, and there's a nodule right there. You're going to press deeply and firmly and scrape it just like I just did. Hold the arm in flexion for about 20 seconds. Then go back on the nodule and apply that 10-second rule. Now if you'll turn around a bit here. Turn around. Now prior to that, the person may have trouble gripping. And so they would have trouble pinching here and holding as you pull through like this on the little finger, the ring finger. They may have a lot of trouble just plain gripping and holding things. So they have trouble writing with a pen, gripping a cup or a glass. Immediately after you release that nodule, all of a sudden they have the ability to pinch the ring and the small finger very tightly so that you can't pull it through, and they can hold a cup and a pen or a pencil very easily now. So that's freeing up the ulnar nerve, which gets the opponent's muscles of the palm of the hand. When I was in chiropractic college, I took care of an older chiropractor after we met at a seminar, and we were talking, and he said, you know, I'd like you to take care of me. I have a lot of things that other chiropractors haven't gotten. I said, fine. And he had to drive 5.5 hours one way 3 times a week to see me. We got rid of all of his pain except sciatica. Now it happens that I read about an impacted molar causing sciatica. And I suggested, you know, I told him about it, and I said, do you have that? And he says, you know, I do, and I've been thinking about having it taken out. Now, he was in his mid to late 80s. So I said, go ahead and have it taken out, and his sciatica went away. So it was due to an impacted wisdom tooth. Now, I've had several patients that came in that was the source of their sciatica also. So it was something that a dentist had to take care of that I couldn't take care of. I also read about an impacted wisdom tooth causing pain, numbness, and tingling in the carpal tunnel area, the median nerve. That also was rectified by removing a molar. I had a patient come in, and she had gone blind in one eye and was going blind in another eye, and it just didn't seem right to me. After several investigations, I said, when was the last time you saw your dentist? And she said, well, it was about 3 months ago. What did he find? Nothing. And I pressed in here, and I found 2 very hot areas of the gums around the molars, and I said, you have 2 root canals right here. Go call up the dentist and go immediately over there. And I had asked her, you know, why she thought she was going blind. She said, well, the medical doctor said I have pancreatitis, and that happens with it sometimes. And one of the things that was happening is green pus was coming out of her tear duct when I stimulated certain nerves. That's what led me to believe this. And I said, they're going to take an x-ray, and they're going to find a tunnel going from the root canal right up to your eye socket, which they did. And the dentist said, who told you about this? My chiropractor did. Chiropractor? So he put a valve in there, and he found that the root canal had been penetrated into the tooth on one. There was pus around the other one. He put a drain in there, and it drained it out, and he fixed the root canal. Not only did it correct that, but her eyesight came back in both eyes, and she didn't go totally blind like she was told she would. So that can cause a lot of problems. 6 months later, she comes in, and just out of the blue, she's hurting all over her body. And it didn't seem right. And I go to the other side, and there was pain in the gums there. And I said, he missed another root canal. Went back, had that fixed, and all the pain over her whole body. There obviously were a lot of toxins coming out of that root canal there. I had another patient come in, and she was just really, really dizzy. And after examining her, there was a lot of stuff I could work on, but that dizziness really bothered me. And I found something on her in a wisdom tooth. And she had just been to the dentist the day before. They cleaned her teeth, but the dentist didn't investigate anything. I said, you got a root canal, go in. They fixed the root canal and her dizziness went away. So a lot of things can come out of impacted wisdom teeth or poisons from root canals and stuff of that nature. So make sure that you take care of those. Now, a lot we talk about biceps tendonitis, and the biceps tendons, the medial head goes up and attaches above the shoulder, and the lateral head also does. And we work up in here, and it can cause a lot of problems. However, I've found that many times you got to go to the tendon on the other side of the muscle, and it can branch out and go to the radius and the ulna. So the ulna and the radius here, and there's a sheath. So rather than work up here, I normally go down here and I use the big ball tip prod, and I just scrape over these areas. You notice I'm going just a little bit deeper than the underlying tissue in order to break up that scar tissue. And then we stretch for 20 seconds. We turn the palm up and raise it as high as we can. So we're in full pronation, and we raise as high as we can for about 20 seconds. Then we go back and we get residual with the 10-second rule, and the tendonitis will go away on the other side. Now, this is technically called the clothesline sign or the tethering sign. So when you take a clothesline at one end and you twist it, most of the pressure is felt at the other end. So clothesline or tethering. We're going to be talking a lot about this as we go now. Now, a patient may be having trouble with the brachioradialis tendon here, and it's not releasing when you work on the tendon. Well, it may be at the other end up in here. And that particular muscle attaches to the humerus about 2 inches. Proper way to get it is to put your thumb right in here and fully flex, and you're going to scrape it with the arm fully flexed. The stretch is to grab the thumb and just go like this with the elbow straight in the Finkelstein's sign, and it'll kind of roll back and forth like this for about 20 seconds. And you come right back and you apply the 10-second rule. How's that now? Good. Now, with tennis elbow and golfer's elbow, this is an exception. Usually you go to the other end of the muscle, the other tendons. On the tennis elbow, you would go right to the source of pain, right where the extensor digitorum muscles attach, which would be right up in here. And you would press and scrape just like that, no longer. Again, you're pressing a little bit deeper than the underlying tissue, and you press and you get off of it. Then you stretch by flexing with the elbow straight. Then you apply the 10-second rule. Golfer's elbow, you go on the flexor digitorum superficialis and profundus, which would be right here, right where they're feeling the pain. And you would press deeply and firmly and scrape just like that, and you would extend the arm and the elbow and the hands. For the 20-second frame, then you would go back and you would apply the 10-second rule to that as well. Now the coracobrachialis, which is the hairbrush muscle, does this movement, attaches to the humerus and the coracoid process. And right next to it, the pectoralis minor, which goes to the 3rd, 4th, and 5th ribs right here. The best way to release those is not to work on the muscles, but rather go right up to where the tendons insert here. Again, you're pressing just a little bit deeper than the underlying tissue stops you, and then you take it back in a stretch like so for 20 seconds, and you go back and you apply the 20-second rule there. Now the deltoid muscle attaches the underside of the clavicle and goes around and attaches the underside of the spine of the scapula. Now you have tendonitis of the deltoid right here, and that's very difficult to take care of, but it really isn't. You take the big ball tip probe and you're scraping under the attachment to the spine of the scapula and all the way around under the clavicle. And here you would stretch 20 seconds this way and 20 seconds like this. Then you would go right back under and apply the 20-second rule to the deltoids. Now, here's where a patient has pain directly on the humerus head right here, and they have pain there. And you've worked on that and you don't know how to take care of it. Well, basically, it's from the attachment of the pectoralis major on the manubrium and the upper part of the gladiolus, about a 2-inch span here. So you would take the spring link or carabiner and you would scrape over that attachment just like this, a little bit deeper than the underlying tissue. Then you would stretch for 20 seconds. Then you would apply the 20-second rule again. You immediately go back and that pain directly on the humeral head is gone immediately. Now again with the pectoralis major, you have a pain that's a little bit lower and it's forward out here and it's not on the humerus head. And you haven't been able to get rid of it. You think it's the pectoralis muscle, you think it's the pectoralis major, pectoralis minor, coracobrachialis, you think it's deltoid tendon, you think that it's, the biceps tendon, you think it's the deltoid, but it doesn't seem to be any of those. And so what I figured out is, you notice that the pectoralis major comes around like this, and under where it attaches to the humerus, you stick your tip of your thumb up under here and it's adhered to the humerus, so you stick it up in there and you scrape it away just like that, and you're peeling it away with the tip of your thumb, and you stretch for about 20 seconds and you go back and you apply the 20-second rule, and that anterior shoulder pain that you thought was so many other things is gone, because it was due to the pectoralis major adhering to the humerus itself right in here. Okay, now the general triceps, you have a tendon sheath that goes up a good third, maybe more, on the back side of the triceps. So here you would take your thumb and you would scrape over that entire triceps tendon right through here to release the general triceps. You would stretch just merely by bending the elbow like this, and you come back and that's released, and that releases the whole triceps. The anconeus is one where you have to scrape directly over the anconeus, and that's a whole muscle thing, which is very rare in my experience. And the stretch is the same as the general triceps. Now the long head of the triceps is different. It goes over the joint and it attaches to the scapula. So here you would take your thumb and you would scrape right at the insertion on the scapula, just like that. You got to go pretty deep, just that long though. Here to stretch it, because it goes over the joint, you have to not only flex the arm, but you also have to extend the arm over the shoulder like so. You do that again for 20 seconds. Then you go back and you apply the 10-second rule. Now for any one of the trapezius muscles, the lower trapezius attaches to the underside of the spine of the scapula. And to release that, you take your carabiner like so, and it's about the lower third like this, and that will release basically from about T5 all the way down to T12 right through this area. The middle trapezius goes from basically about T1 to T4 or 5, and you take the carabiner and you're going to scrape on that whole upper side at the attachment of the spine of the scapula like so. And the stretch for those is to reach across like so for 20 seconds, and then you come back and you use the 20-second rule. Now the upper trapezius, all of us have pinched and rolled on here, and we show you several different approaches in part 1 on that. But a lot of times it's just a little bit of scar tissue right on the tendinous insertion. You're going straight lateral till it attaches to the scapula right here. Stick your thumb in there and you press deeply and scrape just like that. And the stretch is like this, and taking the head to the side. You apply the 20-second rule second and maybe the third time, and tension and pain will release right here that you haven't been able to get rid of at all. Okay, for the levator scapula, you have to go to the angled border of the scapula here. You use the carabiner or spring link and you scrape right on the tendinous insertion right there. Then you go up to the transverse tips of C1, 2, 3, and 4. And since the action is to turn the head toward and elevate the scapula, the stretch is depress and look away. And you apply the 20-second stretch, and then you come back and you apply the 10-second rule. Now sometimes there is a pain just right at the base of the levator scapula, and this has baffled a lot of people doing myofascial pain for a long time. So next we're going to show you what to do about that. So here you have a pain right at the base of the levator scapula, and this has baffled a lot of people doing the myofascial therapy for a long time, but I'd figured it out long ago. Basically, I figured out that it's the anterior attachment of the serratus anicus. The only way you can get to it is to cross your arm in a figure 4 fashion like this. It pops the shoulder blade out. You take the butt of your hand and you shove the shoulder blade upwards. Now you're going to hook your fingers around the front, the anterior superior side of the scapula, and you scrape just like that. You have to be very firm with it. and you're going across the whole top aspect of the scapula. You leave it stretched for 20 seconds, and you come back and you apply the 10-second rule, and this pain that many thought was the levator scapula or the rhomboid minor or the upper trapezius or the supraspinatus actually was being caused by the attachment of the serratus anicus to the supero-anterior aspect of the scapula. And the adductors of the thenar right here, we've worked those out. They don't seem to work too good. Well, the best place is to scrape at the insertion right here, and then it inserts right there between the metacarpal and the phalange. So the attachment is right here. That's the best place to release this particular muscle. When you have muscles attaching to a broad area, such as an interosseous membrane, which could be anywhere right through here or between the tibia and the fibula, you need to get down in there and free that up. And that's usually best done with an elbow, because these others just aren't deep enough. So you need to get right between them, just like this, and scrape those out. And that's the best way to get the interosseous areas. The supraspinatus goes through a tunnel in the scapula and inserts into the joint capsule here. So the best way to free the supraspinatus is to pull the arm back, flatten the muscles here, curl the fingers, and scrape over the head of the humerus like so. Then you stretch for 20 seconds and you go back and you apply the 10-second rule right over that whole joint capsule area. Now you have several muscles that attach to the scapula, and I found that one of the best ways to do it is to carte blanche. If everything is tender, for example, all the trapezius muscles, all the sits muscles of the rotator cuff, the deltoid, the long head of the triceps, the biceps, pectoralis muscles, coracobrachialis, levator scapula, the rhomboids, the latissimus dorsi, if all of those are involved, it's probably because something else is going on. And when that happens, you're going to find that the opposite Poupart's ligament running from the ASIS to the pubic bone is very, very sensitive. That's an area you haven't been able to clear up, for example. Now, that muscle is the internal abdominal oblique, and it crosses over to the external abdominal oblique. That attaches from the 5th rib all the way down to the 10th rib in the axillary area right through here. Now the serratus anicus attaches from the 9th rib to the 1st rib on this side. Usually the problem is involved right in here between 5 and 9 where there's an overlap. So you take the carabiner in your hand just like this, and you're scraping over the 5th through the 9th ribs all through the axillary area, just like that quick. Then you stretch it out for 20 seconds. You go back and you get any residuals using the 10-second rule. You'll find that instantly, without ever going near it, where the internal abdominal oblique attaches to Poupart's ligament, the pain is gone. And all or virtually all the muscles that attach to the shoulder blade have cleared up without ever touching them. And this is not an unusual thing. Probably the person got hit in the side or fell on something in the side or something of this nature. And that's where that came from. So you free that up and it automatically frees all the rest of it up. This is what I call a cascade effect. Now, you have maybe some TMJ issues that haven't cleared up at all. And you can't figure out why it keeps coming back. You've adjusted it, you've worked all the muscles. But one thing that you haven't done, in my experience, is you haven't gotten the temporalis muscle as it attaches to the bone and the mandible right here. So you have the external auditory meatus, and right in front of it you have, right there, you have the TMJ, and then there's a gap, and then there's the bone right here. So you have the patient open the mouth, and use your fingertip, you scrape right on that, just that much, and you have the patient jiggle the jaw back and forth real loose for 20 to 30 seconds. Then you have them open real wide, and you use a 10-second rule to get that out, and like magic, all of the rest of the TMJ muscles release because it was a cascade effect. Everything was protecting that tendon which was damaged, probably from something like chewing a hard ice cube or a non-toasted bagel where you're kind of yanking it and that sort of thing. Now another one is the external pterygoid or lateral pterygoid. Now again, you have the external ear canal, the TMJ, there's a gap right in front of it, and when you open this up, open the mouth up, then your thumb will sink right in that hole right there, and you do this both sides at the same time. You press firmly, internally and externally rotate, just like that. You have the patient jiggle their mouth back and forth for 20 or 30 seconds, and that muscle releases just that quickly, and it's very effective to do that. Now you have a patient that's nose runs all the time like a faucet, and it just drains and drains and drains, and doesn't seem like it ever ends. Well, I had a female work for me that at periods ate a lot of junk food, and there's a biochemical fix for this, which we talk about in part 4, so don't miss that. But mechanically, I found on her, every time that happened, the digastricus muscle was heavy in trigger points. So basically, you go around the jaw, you press firmly and scrape all the way to the mentalis, just like that. And it's very, very painful. And you have the patient open and jiggle the mouth again. This is an occult reason for TMJ problems, because it attaches to the mastoid and the back of the mentalis. Then you go back and you apply the 10-second rule, and just like magic, within seconds the nose quits draining. And what I think is going on here is the body's trying to get rid of waste, and it has to normally drain the lymphatics out of the head and face right here. Then it drains right here behind the sternoclavicular joint. Well, what if that muscle tension in the digastricus is blocking it? As soon as you release it, then the lymphatics start to drain normally right where they should. If they're blocked, that waste has to get out somewhere, so it shoots out the nostrils. Now, I had a doctor in class who was constantly coughing. It was because sinus drainage going in the back of his throat. He heard me say that, and he worked on himself, and sure enough, it was really hot. And as soon as he was done, his lymphatics started draining normally and the cough went away, and he pointed it out to the class. So there's something else that could happen because of that. Now, whenever a patient has any form of headache, one of the first things that I look for is the sternocleidomastoid. And the sternocleidomastoid, you turn the head like this and it pops out right through here. Okay? And it can cause a pain on the top of the head, the back of the skull, across the face, across the forehead, down into the chest. And so 95–98% of the time, if you treat that, you'll immediately get a release in all the headaches without doing anything else. So the thing I ask for is, do you have pain going across the forehead or in the upper eye socket area? If they say yes, then I know it's that. So you take the spring link or carabiner, you have them turn their head, and you press and you scrape on the mastoid, and it also comes off of the occiput and just below it, just like that. Now, when it acts in tandem, when you're laying on your back, then it acts to flex the neck. So the action is flexion and rotation, the face away from the side that you're treating. So the stretch is to turn the face toward the side that you're treating and take it into extension. Again, you hold that for 20 seconds, and then you go back and you get the residuals, and that is a very quick way to release most any headache. Now the scalenes attach up to the cervical vertebra, and they attach down to the first rib, roughly 1.75 inches from the sternoclavicular joint. And it's behind the clavicle, and it goes on the first rib. And you let the head down just a little bit, and you come across and it feels just like a guitar string. And you go out another 1/2 inch, you got one that extends maybe 3/4 to an inch, still on the first rib, and that's the anterior medial scalene. The posterior scalene, you go directly to the side and you press straight down, and it's on the lateral side of the second rib. The stretch is over to the side like so, and you stretch for 20 seconds. Now, and then you come back and you get the residual. Now, what does this do? Well, it pulls forward, so when you have the flexion and extension, it would have the cervical stair stepping on those x-ray findings. But because it pulls down, it can cause bulging, protrusion, or herniation of the cervical disc, or degeneration of the cervical disc. Anterolisthesis. So all of those chronically can be relieved by getting on the tendons of the muscles, and we've all treated the muscles themselves with mixed success, but none of us have gotten on the tendons. And this can be just very quick relief. And we've had people who've had ongoing neck problems for maybe 50-some years that were immediately relieved by just doing this particular move. Now, somebody with chronic suboccipital pain or upper cervical pain, what do you do for that? Well, those muscles go down here and they attach to the spinous process from the side from about T3 down to T7 roughly, maybe a little above or a little below that. You ask which side it's on, they tell you. You take the spring link or carabiner, you go right in between the spinous and transverse process, you press firmly and deeply, just scrape it like that, and you might even come up on the spinous tips. And you stretch for 20 seconds. You go back and get the residuals, the 10-second rule, and immediately the pain, suboccipital pain or tension, goes away because it's the other end of that particular muscle. Now, the transverse carpal ligament, also called the flexor retinaculum, has 10 structures that goes under it. Here you may not have to treat any of those structures, but it may be the flexor retinaculum has scar tissue in it, and you take the big ball tip probe and you're scraping directly over that. You have several muscles that attach into that, as well on the extensor retinaculum. You have several structures going under that that's used to restrain all those tendons, but it can also bind them down and cause a lot of a tendon or ligament or muscle pains in reaction. So you take the big ball tip probe, you go over them, and you stretch them out and you apply the 10-second rule. You also have similar ligaments between the fingers here, just like this between the knuckles, and between the long bones here. It might be on the palmar side or the dorsal side. And this can make a big difference in releasing any of those structures just simply by going over the retinaculums. You can also do that in the ankle in the same fashion. Now when we look at the ribs here, you may have a problem with ribs all the way around. So you would have the patient lay on their side, lay on your right side. And here you would take the S-hook, again like this. Remember, the ribs angle down from the back, so you would get between the ribs, just scrape this way, and you may have to scrape all the way around the back. Again, here's this one, and you have an even smaller ridge, and you just do the same like this. And you stretch the arm overhead in this fashion, and that will release a lot of tension in the ribs and anything ensuing here. So I had a doctor in Salt Lake City who for 22 years had not been able to sleep more than, 24 years hadn't been able to sleep more than 2 hours a night because of a tight band going around his lower 4 ribs. He came to the class, and that's why he did. We had 74 doctors there, and I simply went around all the ribs and rib cartilages in the lower area like this, which were very painful. He stretched, and we went back and applied the 10-second rule, got rid of it. He went home that night and slept all night, 8 hours, the first time in 24 years. And it was simply because we released the scar tissue in the intercostal muscles. Now somebody may have a lot of swelling inside the nostrils, say during pollen season. And you have the zygomaticus muscle on the cheeks. So you'd press very firmly and scrape over the cheekbones, like so. You're pressing very firmly. And you go under the cheekbones, just like this. You'd have them open the jaw really wide and shift side to side for about 20 or 30 seconds. Then you would go back and get the remainder with the 10-second rule, and you'll find that immediately the swelling inside the nostrils will recede. Now, subscapularis muscle, the tendon goes over the humerus head in the armpit area. So with that, you go in with your fingers and you would scrape directly over it, and you would go around the capsule because the joint capsule becomes involved. Now, Nemo says that that muscle is responsible when it has trigger points of swelling in the hand and the wrist. I've never seen that myself, but when you work on this, it causes a lot of pain and numbness and tingling in the hands and the wrists. I've seen that in particular go away when working on that particular muscle, right on the tendon. and you go back after 20 seconds and you get the residual trigger points with the 10-second rule. And the rectus abdominis muscle attaches to the 5th, 6th, and 7th rib cartilage just on either side of the sternum. And it comes down and attaches to the top of the pubic bone. When it has abnormal tension, you'll have a pain on the top of the pubic bone where it attaches. Also, you can have pain on the pelvic floor. You can have discomfort in the lower back because the abnormal tension causes a shifting of the pelvis. Now, because of this, this can cause problems with any of the pelvic organs that are sitting on the pelvic floor. And it can be demonstrated by pressing on the pelvic floor with your thumb, and you may have a problem with retroverted or anteroverted uterus, for example, or bladder. You may have a prostatitis. You may have a benign prostatic hypertrophy. You may have an ED. You may have a problem with the bladder. Any number of things like that. And you may have a problem with the bladder or the uterus or the ovaries falling out, or called ptosis, out the vagina. And when you correct it up here, then it corrects the position of the pelvis, and it can relieve all of those things just very instantly. So basically you would take your carabiner or spring link and you'd scrape 5th, 6th, and 7th rib cartilages on either side like so. You would have the person stretch by arms overhead and dropping the legs off the table to put a stretch on the rectus abdominis. By the way, ptosis of the bladder, uterus, ovaries is called prolapse also. And you do that for 20 seconds, and you lift the legs and the arms back where they should be. You go back and you apply the 10-second rule to get the remainder, and it's just a very instantaneous type of change, and takes care of a lot of problems in one fell swoop. It's kind of a cascade effect because of all those things that are affected by the rectus abdominis. And you may also have a problem with pain on the side of the pubic bone, so lateral to the pubic bone. And this would indicate that there's a problem with the transversus abdominis that attaches to the lower border of the rib cartilage and the lower ribs. Now, when this is involved, it also involves the quadratus lumborum. I very seldom work on the quadratus lumborum anymore because it's usually secondary to the transversus abdominis. So basically you would take your spring link or carabiner and scrape along the lower border of the ribs and rib cartilage all the way around on the side of the pain, and you would have the patient lay on their side, lay on this side, and stretch that area up. So they would drop the leg down, stretch the arm up to put a stretch on this whole area for 20 seconds, and you would go back over the same area applying the 10-second rule. You'll find that the lower back pain over the quadratus lumborum goes away automatically when you've relieved that, and on the side of the pubic bone. Now you may have somebody who has low back pain, but basically it's aggravated when they reach forward. That's a clue right there that it is the latissimus dorsi. Now the latissimus dorsi attaches to the humerus, the lower posterior angle of the scapula, by fascia T5 all the way down to the coccyx, the superior-lateral border of the lower four ribs, and the iliac crest. So when you're having low back pain when reaching, and it can be very low back pain right across the iliac crest in the lower back, could be a tailbone pain, could be in this area. The muscle that opposes latissimus dorsi, the lower four ribs, is the serratus posticus inferior, and it attaches to the lower part of the lower four ribs, and it also attaches to T11, 12, L1, and 2. So you come up here and basically you pinch at the humeral insertion, and you'll find a good amount of pain there. And you just pinch and hold and just ask them when the pain goes away in the lower back, or this lower thoracolumbar area, or on the coccyx. So the person may be sitting on the coccyx, maybe up in this area, maybe here. A good rule is always to get the person in the position of pain and treat them there, and then you're going to get the results. So you would have the person reaching while they're doing this, and for example, coccygeal pain while somebody is sitting will go away. Lower back pain and across the ilium will go away, thoracolumbar, and you have them do it in the position, say sitting or reaching or whatever. And if you don't consider that from about T5 all the way down to the coccyx, you've missed a whole lot. The gluteus maximus attaches to the coccyx, the lower end of the sacrum, and it actually attaches from the greater trochanter almost halfway down the side of the thigh. And so you can have coccygeal pain or sacroiliac pain, or pain in this area down here. And basically you take your carabiner or your elbow and you scrape along that border where it attaches, and at times you may want to pinch the gluteus maximus right here to relieve those particular pains. And the stretch is rotating the leg outward like so, or the knee inward for 20 seconds. Then you come back and you get the residual with the 10-second rule. Now you may have an issue with hip socket pain. And let's have you lay on your left side. In this case, you would ask the patient, where do you feel the pain? Do you feel it more on the front of the hip socket, on the top of the hip socket, or backwards? Now if it's backwards, the piriformis attaches the top of the greater trochanter and it goes over and attaches to the anterior aspect of the sacrum, going actually down to the coccyx. So you would have the patient in this position, you would take your elbow and you would separate the piriformis from the anterior aspect of the sacrum and coccyx like so, and the stretch would be an external rotation of the leg like this, or an internal rotation of the knee, and you would go back and apply the 10-second rule. Now if it's pulling upward, you would get the gluteus medius. That attaches just under the border of the iliac crest. So here you would take your elbow and scrape, 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 just like that. And the stretch would be to take the knee down behind the opposite knee like this for 20 seconds, and then go back and apply the 10-second rule. Now, if the patient is feeling the pressure on the hip socket forward, that would be the gluteus minimus. And here you would go with your elbow under the iliac crest all the way around to the front of the iliac crest. So it would be just like so. And the stretch would be the same as the gluteus medius. Stretch for 20 seconds, and you would go back and apply the 10-second rule. And this is how you can very easily get rid of any type of hip socket pain by knowing where the patient is feeling the pain. Now, the piriformis also, because the sciatic nerve can go above, through, or below it, or any combination thereof, can cause sciatic pain with the piriformis syndrome. So this, working on the piriformis here, would also clear that. Because of the positioning on the sacrum, it can also cause coccygeal pain and sacroiliac pain. So any of those could be handled by working on the piriformis right in that area. Now you have the hamstrings, and when you're looking at the semimembranosus and tendinosus, when you bend the leg up to just under 90 degrees, you can see the tendon pop up. So you pinch and scrape just like this, just like we were talking about earlier. On tendons, you would take the large ball-tipped prod and you would get under the tendon like so, and right at the attachment. And the stretch would be with the knee relatively straight and off to the side for about 20 seconds. And you go back and you get the residual. The biceps femoris would be on this side. Again, you bend it up just short of 90 degrees, the tendon pops out, and you pinch and scrape, and you go under it with the large ball tip prod, and right at the insertion. Also though, this tendon goes up almost halfway in the thigh, so you would take the spring link or carabiner and you would scrape thus. And the stretch would be the same as the semimembranosus and tendinosus. Then you come back and you get the residual with the 10-second rule. This clears up a lot of hamstring problems. Now we're going to look at meniscal issues. And if you have a problem, say with a medial meniscus, you would look at the medial gastrocnemius, and you'd pinch here, and this would be very tender, as would up on the gracilis, semimembranosus, and tendinosus. Basically, the medial headed gastrocnemius goes over the knee and attaches to the back and upper part of the condyle of the femur. And so you would take your spring link and scrape at that point, just like so. With the knee straightened out, you would extend the foot into dorsiflexion to stretch it for 20 seconds. and you would go back and get the residual with the 10-second rule, and immediately you would notice that the gastrocnemius medial head has let up, as has the gracilis, semimembranosus, and tendinosus that also cross over. This relieves immediately pressure off of the medial meniscus. Sometimes you have to go to the upper part of the attachment of the tendon, the fascia here. As it goes down into the Achilles tendon, and you're going to scrape on that upper border, maybe down onto the heel somewhat. And you would take the foot into dorsiflexion. Sometimes you have to scrape the Achilles tendon also, and on the upper border of the calcaneus, take it into it. That could affect that. Normally it's the first. The lateral meniscus, you just do the same on the lateral side to release that, and that takes care of the lateral meniscus issue. Now, normally when you have an issue with the foot into too much pronation or supination, it's because of the popliteus. Now, the popliteus tendon attaches to the lower side of the condyle of the femur, just above the fibular head, and it comes over and attaches the tibia on this side. It's responsible for rotating the foot inward. So if you're having trouble with pronation, supination, you're not getting rid of it, it's probably this muscle being hyper or hypotonous. So you would come up just above fibular head as it attaches to the condyle of the femur, just like this. And since it rotates the foot inward, the stretch would be to straighten the knee and rotate the foot outward. Then you would come back and apply the 10-second rule to get rid of the rest of it, and this would affect the inward or outward rotation of the foot that basically doesn't involve the hip itself. Now, you may have a patient that the whole calf hurts, so when you would pinch the calf like such, that would just make them wild and send them. Well, basically the plantaris runs down the back of the knee and extends maybe 1.5 inches above the crease of the knee and 1.5 inches below. And at some point this patient has like stepped on a curb or a step and suddenly hyperextended the knee. Well, this put excess stress on this tendon for about 3/4 of an inch below the lower part of the plantaris. So you would come in here, scrape it just like so, straighten the knee, take it into dorsiflexion for about 20 seconds, get the residual, and that would immediately let the pain up here, and all the pain in the calf would go, because all that was basically protecting this tendon. Now, the soleus muscle is normally the one that's responsible for Achilles tendon pain. It can be the plantaris muscle itself, in which case you would have to scrape the body of the plantaris, but I don't find that very often. It's usually the soleus. The soleus attaches the whole outer border basically of the fibula, goes across the tibia here and down into this tendon, the Achilles tendon. So basically you would scrape where it attaches just on the posterior and inferior part of the fibular head like so. Dorsiflex the foot like so. It doesn't cross over the knee. So you'd bend it up to 90 degrees like this, 20-second rule for stretching. Then you would apply the 10-second rule to get rid of the pain right here. And as soon as you do that, all of the Achilles tendon pain is gone. Now sometimes you have a female that's having menstrual cramps, menstrual syndrome, and premenstrual syndrome. You may also have somebody that is in perimenopause or menopause and they are having symptoms. Well, you want to have them while they're having the symptoms, and basically it's due to scar tissue anywhere around the heel. Mostly I find it in the middle part of the medial heel, but it can be anywhere. It can be on the outer side, the back side, the upper part, right through here. Basically you just take and pinch and scrape just like this, very firmly and deeply. Then you take it in dorsiflexion, stretch it 20 seconds. And you go back on the residual, and as you're holding it, the menstrual, premenstrual syndrome, perimenopause and menopausal symptoms will go away while they are on the table. Now somebody may have a problem sleeping. They're on their back and it always hurts when they're on their back. And normally they have too much of a curve in their back. This is because of the rectus femoris. It's the only muscle in the quadriceps that attaches above the hip joint. And it's the only muscle in the body that splits into two. The tendon splits into two and attaches to the medial and the lateral ASIS. You take your middle finger like this and you scrape on the medial and lateral side and just below it. And because it goes over that area, you would have the patient lay on their side. Lay on that side, please. And here you would take the heel into the buttock and take the knee into extension to stretch that particular muscle because it crosses over the joint. And you hold that for 20 seconds, lay on your back. Then you would apply the 10-second rule here. Now you do that on both sides. Because it attaches to the ASIS, when it's in hypertonus, it causes the pelvis to rock forward and it puts a kink in the back. So when you release it, now that takes the pressure off. And people say either I can't sleep on my back or I have to stick a couple of pillows under my knees in order to sleep on my back. That's a pretty dead giveaway for it. That also, in Travell and Simons, can cause whole knee pain on the patellar area, right around here. So that's another giveaway for that particular muscle. Now, chondromalacia patella, the way that you tell it's that is they always have crepitus in the knee, and when you put a light pressure down like this and you tell them to forcefully straighten the knee, they try and do that, and then it puts a great pain under the kneecap. That's the test for chondromalacia patella. You will also have a pain when you press on the upper part of the kneecap like so. Well, this is the vastus intermedius, which goes to the middle part of the outer greater trochanter. This one, 4/5 of it is tendon. So you're going to take your carabiner or spring link and just scrape over it like so. And for this, because it doesn't cross the joint, you just merely flex the knee like this for 20 seconds, and you go back and you apply the 10-second rule. And immediately the chondromalacia patella test doesn't hurt anymore. And when you have them squat, now it may take 4 or 5 squats, the crepitus goes away very quickly. So that takes the downward pressure off of the patella. Now if you have outer patella pain, this is due to the vastus lateralis being in tension. So you follow it up to the side of the greater trochanter and use the carabiner again, just like that. You bend the knee, stretch it for 20 seconds, you go back and apply the 10-second rule, and immediately the lateral patellar pain is gone. Medial patellar pain, this is due to tension on the vastus medialis. So you would follow it up to the greater trochanter, and it would be more toward the medial side, and you would scrape on it like this. Every one of these, there's going to be pain right there. You flex it for 20 seconds, you go back, you do the 10-second rule, and immediately the medial border pain of the patella is gone from doing that. Now, the tibialis anticus, anywhere around the whole calf can cause shin splints. Tibialis anticus is what it's mostly blamed on. It's probably true. But tibialis anticus, because of where it attaches here to the upper part of the longitudinal arch, is basically, when it's in hyper or hypotonus, it's the most responsible for pes planus or pes cavus, high or low arches. Now, basically that's caused because it is adhered to the outer border of the tibia right through here. So in this case, you'd either take the S-hook and you would scrape to peel it away from the lateral border of the tibia, or you would take the tips of your thumbs, which I think is a little bit easier. And because it causes dorsiflexion, the stretch is straight plantar flexion. And then you go back after 20-second stretch and you get the residual with a 10-second rule. And if somebody has pes cavus, immediately they stand up and they feel that the pain is off of the high arches. And a lot of times you can see immediately that the flat feet have come up noticeably, sometimes entirely within a few minutes. But normally, because there's a lot of atrophy, when you tell the person to stand, they have to rock their foot out a little bit so that they feel it equally across the transverse arch. And that acts to strengthen the atrophied muscles up so that they pull up. And you have to ask them to start walking that way as well as standing that way, because they're just not used to doing it. Now, the peroneus muscles are the ones that are involved in a trick ankle. So they've turned their ankle like so, and you always have a trick ankle after this. Well, the problem is the peroneus, and basically you're on the where it attaches to the lateral inferior aspect of the fibular head. So you take your carabiner or spring link and you're scraping right up this point. And because it everts and dorsiflexes, the stretch is invert and plantar flex for 20 seconds. And you go back and you get the residual with the 10-second rule, and immediately they stand up and they can feel that their ankle is much firmer. Now, you may have a patient that has pain in the outer 4 toes and in the area just in front of the heel where the quadratus plantae is. Now, the quadratus plantae is the only muscle that attaches to the tendon of another muscle in the body. And that's the flexor digitorum longus, which comes right under here and runs to the outer four toes. Now, the cause for the pain there, which is about, say, an inch in front of the heel, and it's often mistaken for plantar fasciitis or heel spur, which it isn't. Basically, it's because the flexor digitorum longus on the inner border of the tibia is adhered to the tibia. And so you can take your spring link or carabiner and just go on the inner part here, and you're peeling the flexor digitorum longus away from the inner tibia. I prefer just to use the tips of my thumbs. It's like this, and it will be very painful to that patient. And since it curls the toes, the stretch would be to extend the toes and dorsiflex. You do that for 20 seconds, then you go back and apply the 10-second rule. Immediately, the pain in the outer four toes and about an inch in front of the heel is gone, because it's from abnormal tension being put on because of the attachment of the flexor digitorum longus up here. When you have pain in the big toe, it's not a bunion. It's basically due to abnormal tension in the flexor hallucis. Flexor hallucis attaches to the middle of the posterior aspect of the fibula. So you would have the patient in this case stand up, and you would use the spring link or carabiner, and you would scrape, give or take, up the middle part of the posterior fibula in the middle portion where it's attached, and you would have them dorsiflex the foot and the toe for 20 seconds, then go back and apply the 10-second rule. You'll find that immediately the pain is gone in the big toe. Now, sometimes you do have to treat the quadratus lumborum. For example, if somebody has pain mainly when they're sitting or standing, you would have to get them in that position. And so basically you would take your thumbs, you would come up under the ribs, because quadratus lumborum attaches to the bottom of the 12th rib, and the tip of the transverse process of L1, 2, and 3, 4, and 5, which is the iliolumbar ligament there, and across the iliac crest like so. So basically you would come up under like so, you would scrape that under part of the 12th rib, and you would go on the tips, the transverse processes, and then across the top of the iliac crest. Sometimes you got to take your fingers, go like this. Then you would have them take their arm and shift to the side to stretch this whole area out for 20 seconds. And the other side for 20 seconds. And you would come back and apply the 10-second rule. And then that would take care of it there. But you have to get it in the position where it's hurting. So if it's hurting sitting, or sitting leaning forward like on a toilet, or standing, bending slightly over at a sink, that's the position that you would need to get them in. Now if somebody has a back pain, say in the sacrospinalis or in the general back area here, the rhomboids or etc., you take your carabiner, ask them where the pain is, and you just take and press, and you just go over that one spot. Just like this. Again, you're pressing very firmly while you're doing it, but it's just that quick. Then you have them stretch for 20 seconds, then you apply the 10-second rule. Now when I was in Salt Lake City, there were 74 doctors there, and somebody yelled, "Patient coming up front," and I was still talking. Usually they asked to come up front. This guy just came up front and just stood beside me. And I finished what I was saying. I said, "How may I help you?" And he says, "Well, my back has hurt for well over 20 years. And I've been in this back brace 24 hours a day for 8 years because it hurt 24 hours. I said, "Okay, take it off." So I had him take his shirt off and the brace off. I said, "Point to where it hurts," and he pointed at about this area right here. So I said, "Sit down," and I just did what I just described on him, had him stretch, got the residual, and I said, "Okay, stand up." He stood up. I said, "How's the pain?" And he said, "It's gone." I said, "Try moving around, try to aggravate it." He twisted, he bent forward, he bent back, bent to either side. He said, "I can't believe it, the pain's gone." And all the treatment on him took less than a minute, and it got rid of all that pain he'd been dealing with for well over 20 years and wearing a back brace for the past 8 years. In the break right after that, doctor that I recognized his voice, he said, he came up and he said, "I'm so sorry for him just walking up there like that." And see, the guy said that his father-in-law had him come in. I said, "Oh, that's okay, you're his father-in-law." He says, "No, I'm not. You don't understand. His father-in-law isn't here. He sent him in there just to humiliate you, because he sent him to every seminar that has ever been here in Salt Lake City, and nobody could help him." And he says, "I don't understand. You just got rid of the pain in less than a minute." And I said, "Well, you know, that's how well this works." Now, I was up in Nebraska, and there was a professional triathlete there, and he had a pain in the middle back, like right in here, and nothing I did got rid of it. And so I went right on the periosteum of the spinous tips, and he had extreme pain in about 4 of them. I went over it about like this. I had him stretch for 20 seconds, then I got rid of the residual, and all that pain was gone. And that had been there for almost a decade in this poor guy. And he'd been from seminar to seminar and nobody gotten rid of it. Literally, it took less than a minute just by going on the periosteum of the spinous tips. Now you have the flexor digitorum brevis, which runs from these outer 4 toes right up to here. They kind of run around this way, right in front of the lateral malleolus. And so this is for people who have like the toes raised up like this normally. And so I was at a seminar, I believe, in San Antonio, Texas, and this gentleman is in his late 70s, early 80s. He had these toes just picked up like this, and he says, "Nobody's ever helped this." And I've been to several seminars for decades. I said, "Okay." So we just took this, and remember, they run just like this, streamers like so. And there wasn't anything out here. And these two, I went right in here, and he about came unglued. And so I stretched him for 20 seconds. And the treatment was just that fast, by the way. Then I got the residual. Now before that, he could not curl these outer 2 toes. After it, he curled them perfectly. It was this muscle in the extensors that was preventing him from being able to curl those toes for several decades. And it really is that simple. You just have to use that tethering or clothesline effect and go to the other side of the muscle virtually every time. Now you may have a pain right here in the back part of the longitudinal arch. Well, this is from the tibialis posticus muscle running up through here, but it's basically the tendon that is not excursing properly behind the medial malleolus. So in this case, you would take the carabiner and you would scrape behind the medial malleolus to unadhere that tendon from the tibialis posticus. And the stretch is dorsiflexion of the foot, like so, for 20 seconds. Go back and get the residual, and immediately the sharp pain right there at the back part of the longitudinal arch will be gone. Now you may have a patient that has a hernia, and basically consider that a hernia isn't from a sudden accident, it just is a parting of connective tissue. Well, why does it do that? It does it because there is a constant tension that wears down the connective tissue. So basically we have to remove that constant tension. So you basically have the patient tense their upper and lower abdomen, so they're going to crunch here, they're going to lift their pelvis here, crunch down, and you're going to take your fingers and scrape real hard from about the 5th rib all the way through, just like so. When there is a bad area there, they will let you know. Then you stretch with the arms overhead and the legs down for 20 seconds. Then you go back and you get the residual. And I found about 60%, and probably I could get higher than that. That's all I've seen so far. 60% of the hernias, when you take that excess tension away, will reseal with scar tissue without ever having the surgery. Now, you have the diaphragm. The diaphragm attaches from the 5th rib area down through all the ribs lower down to the 3rd lumbar. If you have a patient that has recurrent pain and tension there, it's probably because of the diaphragm. So through the diaphragm also, besides the cisterna chyli draining the lymphatic fluid, you also have 3 major veins, the abdominal aorta and the esophagus. So it also attaches to the xiphoid process, and so you can have reflux esophagitis, hiatal hernia, you can have circulatory problems going to and from the lower extremities or the abdominal contents here. Well, if you have somebody that's overweight, and no matter how much exercise they have or how much they diet, they can't lose the weight, it's probably because the lymphatic fluid is not draining out of the lower extremities and the abdominal contents because of too much tension in the diaphragm. So the way you take care of that is you have them sitting in a chair and you have them lean forward, just slouch forward, and you hook your fingers up under the diaphragm like so, and you're scraping on the back part of the rib cartilage and the xiphoid process and the ribs, just like so. And then to stretch, you have them just lean back over the chair with both of their arms up, and that stretches it out for about 20 seconds. And you go back and you apply the 10-second rule. An amazing thing about this is you got somebody that's extremely overweight or even a little bit overweight and they can't lose that weight, they will automatically lose maybe up to 30 to 50 pounds of just fluid just by uncorking the tension here. besides all those other symptoms that may go with it. So you can amaze your patients by helping them to lose weight just by taking the tension out of the diaphragm. Remember, all those areas from T5 down to L3 where they've had constant tension that you can't get rid of, it's most likely due to diaphragmatic tension. Now, a patient may have myalgia paresthetica, so you can have pain, numbness, and tingling going down the thigh through the foot and ankle, and swelling on one side, which is kind of a dead giveaway. And it has to do with the femoral triangle here. Now, I found that an easy way to take care of it is to go on the vastus, the adductor magnus on the medial border of the femur here, and you have them externally rotate the leg. You take your elbow and you scrape along that medial border just like this, and you take it into abduction for about 20 seconds, and you get the remainder with the 10-second rule, and immediately this will help all the paresthesias in that leg and foot and ankle, and this basically is putting pressure on the lymphatics on this side, so the swelling unilaterally will drain out. Now, you may have some cysts somewhere in the body. For example, you might have polycystic ovarian disease, ovarian cyst, you may have a Baker's cyst, something of that nature. Well, this is due to scar tissue or muscle tension preventing the lymphatic drainage out of that area. If it's an ovarian type of cyst, you would use your fingertips to go in and free that tension up around the ovaries, and that will gradually drain that out. If it's a Baker's cyst or something on that order, you would have one of the larger ball tip prods, and you would scrape over the cyst and immediately around it, and then that would relieve the tension and the cyst would start to drain out. And where it's herniated through, it would start to seal back over again. Right, heel spurs. There are 4 main heel spurs. The one that everybody associates with comes right off of the anterior middle part of the calcaneus and goes forward. Then you have a medial one, you have a lateral one, and you have one up the Achilles tendon. All of them are traction spurs. Now, the way that you take traction out is, we already described how to take the traction out of the Achilles tendon by working on the triceps surae, which is the gastrocnemius, the soleus, and the plantaris. So go to that section. On the medial, this is the adductor hallucis. And the way that you take care of that is the same way that you take care of bunions. Now, the bunion is out here and it's pulling the big toe over. And the way that they do surgery is they whack the bone off and they snip the adductors, adductors, so that the abductor hallucis is unopposed. But actually there's an easier way to do it. So I always ask the patient, even doesn't matter how far they have the toe crossed, you know, try and spread your big toe, and they can't do it. And normally what you hear is to work on the adductors because it's pulling it over. But I started thinking, because it never worked out too well. So you get the spring link or carabiner here, and you go on the broad attachment of the abductor hallucis right through here, and you're pressing and scraping just like this, deep and firm. While you're doing it, you're holding the big toe out to the side to help it. And you hold it for 20 seconds in the stretch. You get the residual, and you'll find immediately the person can start spreading the big toe where they had no action whatsoever before. And on the outside, it's the abductor digiti minimi. You would have something similar, except you would go right up to where it attaches to the lateral border of the small toe up in here. Before that, they couldn't spread the little toe. Now, all of a sudden, they'll be able to do it. Now, that will start to take the traction off of these areas, and eventually the spurs will go away by losing the name of it. Okay, I'll have to do that later. You can also accentuate them going away by putting a coating of liquid iodine on and using phonophoresis or electrophoresis. The way that the tension puts the calcium in there to start with is by the piezoelectric effect. And so when you take the tension off, the piezoelectric effect changes because of the different stresses on the tendon, and the calcium starts to go out, albeit it'll take a lot longer. So you may want to speed it up by using the iodine solution in that manner. Now, you may have plantar fasciitis. Now, plantar fasciitis is one of the most overdiagnosed conditions in the human body. And you go into a doctor and they say, you hurt? Yeah, where? At the bottom of the foot. Oh, plantar fasciitis. It, most of the time, is a single muscle. It's got nothing to do with the plantar fasciitis. Now, the spur coming off of the mid part of the calcaneus is coming off of the flexor digitorum brevis, and that is the most often mistaken for plantar fasciitis. So you take your carabiner or spring link here, you're going to scrape over the tendons from the base of the toe down about so far past the transverse arch. And then you take it into dorsiflexion, and you get the residual with the 10-second rule. That will take care of that. If you have a true plantar fasciitis, basically you want to take the toes into a dorsiflexion, and you would scrape over the entire bottom of the foot where the pain is, like so. And you hold it into extension for 20 seconds and get the remainder, and it comes out really in a matter of a minute or two, and it's very easy to do. Now, you have something like this in compartment syndromes that can happen in a lot of various muscles, and surgeons go in there and they split the fascia that's covering the muscle because the flat fascia has constricted, and it's constricting so much it's cutting off the blood supply and putting a lot of compression on the nerves and lymphatics and etc. Well, you don't need to do that. All you need to do is stretch the muscle and take your carabiner and scrape over it, pressing very firmly just like this. And you can get rid of a compartment syndrome in a matter of a minute or two just doing that, by freeing up the scar tissue and whatever muscle that is being affected. Now, if a patient has bowed legs, it's basically due to their gracilis having too much tension in it. So it's pulling in like this, and that comes out of the pes anserinus. Well, you take your carabiner and you're scraping that inner part of the tendon, and you stretch it by abducting it for 20 seconds. and you take the remainder out here. Now, right after you do this on both legs, you immediately have to take and push them together. A lot of times you may have a bow this much, and after you push them together, you can barely get your hand between the knees, but you have to push it together directly afterwards. When you have knock knees, it's because of the iliotibial band out here, and so you would have to take, again, the carabiner or spring link, and you would scrape from the top of the fibula and scrape up maybe to about 3 or 4 inches above the crease in the knee, like so. And then you would stretch it this way, and then you would go back and use a 10-second rule to get the reminder, and immediately afterwards you would press the ankles together. And I had one person who was 14.5 inches, another 9.5, another 5.5, and immediately after I did this on both knees, I pressed it together. For the first time in their life, their knees and their ankles were together. Standing, laying down, whatever. So this can be very dramatic very quickly on conditions like that. Guillain-Barré syndrome. Guillain-Barré syndrome, basically I had a pastor and his wife bringing their little son, 7 years old. He was walking with his legs straight, and I said, why doesn't he bend them? Well, he'll fall to the floor. Nobody knew what to do with him. And I tried to do a leg raise on him, and I couldn't even lift it up. As soon as I started, he had severe pain in his lower back. If I tried to bend his knees, he had severe pain in his lower back. So I said, okay, we need to start stretching him, and I said, you cannot let his pain and agony dissuade you from doing this, because what you have here is you have the sciatic nerve going to the filum terminale, which is the end of the spinal cord, and it's causing a severe stress on it. So we have to break up that scar tissue, and the only way that we can do it is by stretching. So we started by holding one leg down above the knee, and you hold it up as high as you can until you feel a dead stop for 20 seconds, then you release it. Then you do the other side, and you do each side maybe 3 times. I told them, you got to do this 5 times a day. And so they brought him into the office every day, and in about 2 weeks we had him doing splits with no pain. And then I started bending the knee here, and he still couldn't stand it bending the knee. So we had to do the same thing with the knee until we got the knee into the chest on both sides. And that took another 3 weeks or so. And now he was walking very normally, and he didn't have the pain in his back when we tried to do this. So, but about that time, the mother said, look at his hands, doctor, and the dorsal interosseous muscles were sunken in. And that was a dead giveaway, because Guillain-Barré starts at the lower body and the muscles fail, goes through the whole body, and at the end you have this, as opposed to ALS, which is, this is the first sign and symptom. So I said, you got to take him over to this neurologist. Neurologist said, oh, that chiropractor's crazy. Well, you know, I need to send you to a physical therapist. Well, what would the physical therapist do? And he told them, he said, well, that's exactly what the chiropractor did. You're the one that's crazy. So they came back to me. I said, what do we do now? And I said, well, I'm going to send you to the children's hospital in Oklahoma City. It's a teaching hospital. And so they went there, and there was a 95% consensus amongst 100 doctors that the child had Guillain-Barré syndrome. Now, the problem with it, and the reason that I sent him out, is as the muscles fail, eventually muscles of respiration fail and the person suffocates because muscles of respiration aren't working. So you have to have handy some place with an iron lung for that. Anyway, they took him there and they held him for a couple of weeks. They said, you know, this is the oddest case of Guillain-Barré we've ever seen. And they said, why is that? Well, usually you don't gain the ability to walk back until it's gone through the whole body, and this happened long before that, and the lungs didn't fail. So basically when we broke up that scar tissue, we took the pressure off of the spinal cord, and apparently that attenuated the Guillain-Barré and kept it from doing what it normally did. So this is how you help Guillain-Barré syndrome not to spread and how to attenuate it very quickly. This ends film of TTAPS Part 2.